Menopause is a castration event, whether we like it or not.
Dr. Rubin, I'm so glad you're here to talk about perimenopause, menopause, sexual health.
Perimenopause is hormonal chaos. Your sleep goes to your memory, your mood changes. There are things that happen to every single woman. And the truth is, there are hormonal reasons for all of it. My job is to get you to try to feel as much like yourself as possible. Who is not pro Viagra? I think Viagra should be in the water.
They said to me, you're aging in reverse. And I didn't want to tell them that I'm putting vaginal cream on my face.
I'm not mad about it. I'll get hate for this because people are still pushing the narrative of like, stop scaring women.
I'm going like this because I'm trying to hold the steam in my head.
It is natural, but so is losing your eyesight, so are hemorrhoids. So
we can fix those things
We
now.
have technology, we have biology to help you not suffer. And I hate when women suffer when they don't have to.
This show is sponsored by United Health Group. We know women live longer than men, but did you know they spend 25% more of their lives in poor health? How can that be? Well, it's that women's care is often treated as isolated moments instead of a lifelong experience. That's why United Health Group is working to reshape women's health with a more connected approach to care, supporting women through every stage of life, from adolescence to menopause and every moment in between. This year, United Health Group was the first to expand coverage for doula care nationwide, helping more women access personalized support before, during, and after birth. And through community partnerships and in-home care, United Health Group is helping women with the greatest needs detect and prevent diseases like cancer and heart disease earlier. Because women's health is more than any single diagnosis or moment in time. It's about care that follows women throughout their lives.
Dr. Rubin, Rachel, I'm so glad you're here to talk about perimenopause, menopause, sexual health. Everywhere else we go in this conversation. You are also my doctor, and we've had these conversations in the past, but I'm glad you're going to be able to share so much of what you know with our audience. Good to have you.
Thank you so much for having me. What an absolute honor.
So I think first the question is, why is there still so much misinformation when it comes to menopause?
Yeah, I mean, it seems like everybody's algorithm, at least my algorithm right now, everything is about menopause. And if you ask my husband, we have to stop saying that menopause is not being talked about because it is being talked about a lot more. And he gets very annoyed about that. But the truth is it's just kind of new for everybody. It's almost like we're all waking up from a nap and sort of realizing like, oh, we never really talked about this before. I think it's because of a few things. One being, I have a theory actually, and hopefully you don't take offense to this. I think it's because of all you journalists that are going through perimenopause and menopause, and you're kind of pissed off, and you're kind of like, why? You're starting to not feel like yourself, and you have access to the world's leading experts, and you don't always have the answers. And so I have found that it is because journalists have started asking the questions, and then you have this groundswell of social media and doctors getting onto social media and being loud, and I think that has exploded. So we're seeing more books, more podcasts, more news articles, legitimate news articles, and so it's gotten really popular.
I also think because it's a symptom of the lack of research and care in women's health generally, and because all women go through menopause, it's like, how is this never been talked about and not taught in medical school? And so that causes, I think, a lot of the outrage and anger.
As it should. It's an actual nightmare. The data is very clear that less than 7% of anyone training in gynecology, internal medicine, family practice get any training whatsoever in menopause. And so if you have nobody in the medical schools who know how to teach it, like, it's not going to get taught if it's not part of the curriculum, and it's not really part of the curriculum for anybody. And so we have to change this. Like, we have a solvable problem, but we actually have to have people and human beings try to solve it.
Mm-hmm. For me, it started a while ago, I would say, probably my late 40s. Now, I was commuting back and forth from New York to Washington, and I felt like someone was in my head flipping a switch. Like flipping it, something just went, oh my gosh, something just happened to me. And my doctor chalked it up to being tired and having 3 young kids and working really hard. But now looking back, I see it was probably something else. And one of the things that's so interesting to me, and I want to talk about what chemically happens biologically happens in the body, because you've described it as a castration. of hormones. Explain that.
Yeah, a lot of people don't like that I say it, so it just makes me say it more.
Me too. That's why I brought it up.
So
Because you know why? It makes you listen.
it makes you listen. So menopause is a castration event, whether we like it or not, whether it's natural or not, whether it's supposed to happen or not. We are outliving our ovaries. The ovarian function turns off for 100% of women who are old enough to experience it. And the average age is 45 to 55. So we think of menopause as old people. It's not. You are no longer old when you're 45 to 55, but it is a castration event which will affect you. It will cause symptoms, and it will be different for everybody how severe the symptoms are, how much you want to put up with the symptoms. But there are things that happen to every single woman.
What gets castrated?
And so your ovarian function is no longer making estrogen, progesterone, testosterone. You're not making the hormones that you were during your reproductive years. And that has consequences because you have hormone receptors throughout your entire body. So it's not just hot flashes and night sweats. So I've been quoted as menopause has the worst PR campaign in the history of the universe because it's not just hot flashes, which are a nuisance. Hot flashes are actually quite dangerous for your health. Not only that, your sleep goes to shit. Your memory, your mood changes.
There are estrogen receptors in your brain. They're everywhere.
Right. So you get brain fog. You get the, oh my gosh, I swear, I know the name. Oh, this is a book. I forgot the name of this thing. You kind of have word zaps, I call them. You, as I said, your sleep isn't great. People get musculoskeletal symptoms. People get itchy ears and dry eyes. They get urinary tract infections, pain with sex. Their orgasm changes. Women aren't walking around thinking, my orgasm used to be more powerful and now it's just kind of a blip. It can happen. Or some people say, I need a device or it's not happening anymore. And they just assume it's aging. And the truth is there are hormonal reasons for all of it.
And what's the difference with men then? Their hormones, though, are more of kind of, they fall off too, right?
Yeah, so men experience, and not every man experiences this is sort of a natural decline in testosterone, but an age-related decline, but even that isn't really true. But men don't really get to castrate levels. I always say, I love this gas tank analogy I often use, is women, their gas tank is 0. Men, they kind of live at like a half a tank. And maybe if they get to a quarter of the tank, they can go to their doctor, they get some testosterone, and they go back to half to 3/4 tank and they feel great. Women, I just got back from lecturing 2,000 primary care clinicians about how to prescribe hormone therapy and why they shouldn't be afraid of it. And one of the things that I say is, what other organ do we let fail entirely before we help? Right? Your kidneys do not completely shut off before we start treating you and then eventually put you on dialysis. Your liver doesn't fail completely before you get on the transplant list. And yet your ovaries are failing completely. They're failing for about 10 years before they fail completely. And you are symptomatic during this time. And doctors are saying, oh, you have to wait 12 months of complete empty before we intervene, and you have to be bothered enough. And oh, by the way, we forgot to teach doctors how to treat you.
I also think that the word castration, while as difficult as that may be for some people to hear, it is this wake-up call, as you point out. But there's so many changes because of the multiple estrogen receptors throughout the body and other hormone receptors in almost every cell in your body, correct? Mm-hmm. Things like weight gain. All of the sudden, and I have, seen it in myself and I've seen it in friends, all of the sudden, maybe in the 50s, everyone starts to get a little bit, their weight changes, that it's a lot around the stomach area. Why is that?
Yeah. So again, we see an increase in visceral fat. We see a change in your ability to lose weight. All the stuff that used to work doesn't necessarily work anymore. And this isn't being studied to the level that we need it to be studied. And hopefully that's changing. But again, it's one of the very common complaints that we have. And unfortunately, our answer is always work harder. Eat better, do more exercise, right? Just try harder. And it doesn't work for a lot of people. And I think,
meaning like if you go to the doctor and say, all of a sudden I haven't been feeling the same and I'm putting on all this weight, that a lot of us were being gaslit in the back and just saying, well, you need to be working out more and not eating as much and stop drinking wine, blah, blah.
I think, so when I spoke to these primary care clinicians, this woman came up to me. She was in her 70s, this lovely older primary care clinician, doctor. She came up to me, she said, I've been telling people to exercise as my only option for all these years. And your lecture just taught me that maybe there's some other stuff I should be considering.
This is an MD.
A doctor. Her mind was completely changed, but she was able to come and tell me that and to say like, hey, all I've been telling patients is just exercise more. But she said, I've been exercising and I still have osteoporosis, right? And so she realizes that maybe that advice isn't the best.
You bring up a really important point, which is, and I want to get into what are the types of hormone replacement therapy. But if you don't go on hormone replacement therapy, what are some of the outcomes that may happen that are really deleterious to your health?
Yeah, people love to talk about, the risks of hormone therapy. Hormone therapy is dangerous. But what do we flip that? What are the risks of not going on hormone therapy? So there are the unknown risks of not going on hormone therapy. Listen, we're all going to die. Every single one of us, right? Like that's where we're all going. And so the real question is, how are we going to live?
This is about improving our health span.
Yeah, what do we want life to be like? My grandmother was 90 in the nursing home. She had quite a long life. She took no medications, but she had osteoporosis and dementia. She did not know who any of us were for the last 10 years of her life, and she didn't have much quality of life. And so we really have to ask ourselves, what do we want the years to look like?
You think if your grandmother had been on hormone replacement therapy, the end of her years would have been different?
Potentially, right? If we could prevent osteoporosis, right? I think the dementia data, we have a long way to go for our full understanding of that. But for the osteoporosis data, absolutely. My grandfather hugged her and she broke all of her ribs, right? I think all of us want to be able to withstand a hug as we get older. But the truth is, what are the risks of not going on hormone therapy? And so osteoporosis, if you fall and break a hip, you are a very high likelihood of dying or not being able to get back to the life that you wanted to live. So bone density is really important. And the thing that I talk a lot about and care so much about is the genital and the urinary symptoms that happen without hormones. And we know that hormones prevent urinary tract infections. Local hormones prevent urinary tract infections. So you don't even need high doses of them. And they're safe for everybody to take. And so the 70-year-olds, 80-year-olds, 90-year-olds and beyond, right, are going to urgent care. They're going to the hospital. They're going into the ICU with urosepsis, which we can prevent using hormones.
This is such an important point. And having talked to you a lot, I know how passionately you feel about this. So I would say, generally speaking, correct me if I'm wrong, that for most people, when they go on hormone replacement therapy, they're taking a systemic estrogen, right? Either through a patch or a pill, right? Mm-hmm. Please correct me if I'm wrong. I'm not the doctor. A progesterone, which they normally take at night, a progesterone pill that will help them sleep. You are then saying there should be additional things on top of that. I think those are the basics that like a lot of my friends are on. But you say there should be more than that, including vaginal estrogen. Why?
Yeah, so not everyone may choose to take a whole body estrogen or a whole body progesterone, but everybody should be offered and given the chance at vaginal hormones and at any age. Everybody. Why? Because no one wants to die of a urinary tract infection. Everyone wants to wear pants. Everyone wants to sit and get through their movie without having to urinate. Everyone wants to sleep through the night without having to get up to pee. And so what happens to the genitals and the urinary tract, if they do not have hormones, they get dry, they get thin, they get irritated. It's like a plant needing water, right? A plant needs water to be fully healthy, to be robust. And that's what happens to the genitals and the urinary tract. And so actually hormones keep the tissue acidic so it can fight infection. And so we talk a lot about microbiome these days, right? And the most important thing for your vaginal microbiome is to keep an acidic environment with hormones. And it turns out if you microdose hormones, you can do a very small amount, very low dose into the vagina. It fixes the microbiome of the urinary tract and can prevent urinary tract infections by more than half. And data shows we can prevent sepsis, hospitalizations, even death in anyone with recurrent urinary tract infections. And so it is the thing I talk about ad nauseum because it is so easy to do. It should be covered by your insurance. It should be inexpensive if it's not covered by your insurance. It's an easy prescription to write. We wrote guidelines to support this. It's supported by the American Urologic Association. And yet, my colleagues published that less than 9% of Medicare patients who have a diagnosis and should get this prescription are getting it.
You mean less than 1 in 10 older women are on vaginal estrogen, and you think if they were, it could save their lives.
We published that we could save Medicare between $6 and $22 billion a year if women were given vaginal estrogen. And that's a conservative estimate. Why? Because not only are those the costs for going to urgent care, for the prescriptions, for the urosepsis ICU admissions, for the hospitalizations, but what about the missed work days? What about the you can't go on your vacation? I had a patient just a couple weeks ago. She got a UTI on a cruise, ruined her cruise, right? It was miserable. She got antibiotics from the cruise doctor and she didn't get better. She came home and then she couldn't go on her trip to Europe because she wasn't better from this infection. And so the lost cost to that family was huge, but also just her quality of life. She was miserable and she actually had to drive from, New York City to DC to see me because nobody would help this woman.
Julie, my producer, would be very upset because she loves cruising. So she would say, this is definitely a travesty. This is definitely a travesty. The other thing is there have been celebrities and very prominent women who are in their 70s and 80s that you worry are at risk because they're not on vaginal estrogen.
Well, so what Nora's not telling you is that I text Nora regularly because I am very worried about certain people not being on vaginal estrogen. Number one being Dolly Parton. So if Dolly Parton is not on vaginal estrogen, I just can't live life knowing if she's not getting good advice.
So people will say, wait a minute. Why is Dr. Rachel Rubin talking about Dolly Parton and vaginal estrogen?
Because Dolly Parton has publicly talked about being sick with kidney stones. She's talked about being sick and having a hard time getting her health back. And that's why it's been difficult for her to go on tour and go back into her entertainment, which she is literally a national treasure, as we all know. And so what my urology brain does is says, we have guidelines by the American Urologic Association for the genitourinary syndrome of menopause that we must help Dolly Parton's microbiome. And the best thing she can do is put a tiny tablet twice a week. It's 10 micrograms of estradiol twice a week vaginally can prevent urinary tract infections and hospitalizations. And so if Dolly Parton's been hospitalized, now that's not going to prevent her kidney stones, but for her healing from her kidney stone surgeries and things like that. And so I'm not Dolly Parton's doctor, but I know that people like you who interview everybody in the world, that you have access to these people. So I constantly bug Nora and I say like, hey, can you just make sure she's getting good medical advice? Because unfortunately,
and just so you know, I don't know Dolly Parton well enough to give her that advice, but I do think this is
not yet.
But this is an important conversation to share because here is the expert on this, a urologist who has studied this, has done the research, and you want to raise this as a national emergency.
But you have to understand that the rich ladies are not getting good medical care here, right?
Some of whom are your patients.
Some of who are my patients. And so the people who have the most resources are not getting good information because we forgot to teach doctors how to do this and why.
But if wealthy women are not getting this care, what about the rest of the population?
Correct. It's horrible. I say it's the most equitable thing in the world because no one's getting good care. Listen, Oprah had to have hot flashes she had heart palpitations. She says this publicly. Again, not my patient, but call me Oprah. I'm happy to help. But the truth is Oprah had heart palpitations and nobody could figure it out. She figured it out herself. Halle Berry publicly said that she was diagnosed with herpes, right, when she actually had genitourinary syndrome of menopause. Halle Berry literally doesn't look like she's in menopause, but she is. And so her doctor did not know that vaginal hormones was going to save her and help her genital symptoms. And they said, oh, this must be herpes. It wasn't herpes. And thank God for people like Halle Berry who publicly talk about this and all the celebrities who are really starting to talk about this because I think it's really important, right? Naomi Watts writes a whole book about menopause. And so it makes it realize that it is young, hot people who are having these symptoms. Amy Schumer has been very vocal about this. And so it's really important that we understand that there are really, we should be talking about this in our 40s. We definitely should be talking about it in our 50s. But even Dolly Parton in her 80s should be talking about this because vaginal hormones can save her from urinary tract infections.
Now, this is the thing that people may freak out about, that you actually lose a body part during menopause.
Yeah, so we went very viral last year. I did a podcast that's not nearly as popular as this podcast, and congratulations, you're amazing. I did a very low-key podcast with a friend of mine, and I talked about how in menopause, the labia minora, those inner wings of the vulva, they actually resorb in menopause. So they can
reabsorb.
They reabsorb. Yeah, they reabsorb and they shrivel up and kind of disappear. Now, not everybody's does that, and not everybody's goes away completely, but it is medical fact that part of this syndrome, this genitourinary syndrome of menopause, they start to go away.
Okay, how do you stop that from happening?
We actually don't know. So science has...
Well, the vaginal estrogen doesn't help?
We don't know. No one's ever studied it. Literally, no one's ever studied it. Science has completely...
We need to get on that, Dr. Rubin.
Listen, if you all want to fund my nonprofit that I have, please, because we need to do research and things people care about. The NIH is not going to be giving a big grant about labia minora research, but my little tiny little, we'll happy
we could
to
get
take.
you some shirts that say "Save the labia minora."
I'm on it. We need swag. We need all the things, but we need to do research on this. Like, science hasn't studied: is it estrogen? Is it progesterone? Is it testosterone? What hormone is involved with the labia minora?
I love the story that you opened up your own sexual medicine practice because people told you it wouldn't work.
Yeah. So when I came out of my fellowship training, and by the way, when I graduated, there was one fellowship in the entire country that even acknowledged women's sexual health. That was in 2016. Today in 2026, 10 years later, there are 3.
Really?
2 that just started about 2 years ago. So we have no training in women's sexual health. I did the only fellowship in the country at the time.
You're the pioneer.
My mentor, I would say, is the pioneer. Erwin Goldstein, a man who actually invented Viagra, essentially, was the pioneer because he started the field of women's sexual health, and I am lucky enough to have trained under him. And so when I came out of my fellowship and wanted to get a job, the academic centers, they said, "Ooh, what you do is weird, and you're not going to make us enough money fast enough." So I went to the big urology practices, and they even handed me a contract, and then they took it away because the private equity firm said, "Ooh, you're not going to make us enough money fast enough. You actually want to spend time talking to people? That doesn't make money. You're not going to be doing enough surgeries." Like, that is not going to be a financially viable way to have a business. And so I had to start my own business, right? I had to start my own business. And unfortunately, like a high-priced lawyer or a plastic surgeon or a dentist, I don't take insurance because my model is about spending time with people, because your sexual health, your quality of life, you understanding your body takes time.
And now your
matters.
clinic is thriving.
And now we have a very long wait list. We have 4 doctors. We're bringing in another one. We're doing great because people invest in time spent and they invest in their healthcare. To be fair, we don't do life and death medicine. We're not an emergency room. Plastic surgeons also do not often take insurance. Like, there are models of healthcare where it's very difficult to get insurance companies to care about what's going on with you. And truly, we do everything we can to get your insurance to pay for medications, to pay for the things that you need. But the time spent with your doctor, you deserve more than 10 minutes talking about your sexual health and understanding what's going on with you. Puberty hits and the whole body morphs and changes. The labia grow, the clitoris grows, the area becomes pink, it becomes lubricated. You can put tampons in, you can have sex, babies can happen. And so the whole genitalia, just like the breast tissue, are hormone sensitive. And so they transform. And guess what? Just like you fill the receptors, then when you go into menopause, you lose those hormones, the hormones are leaving your body. And so everything sort of shrinks and can become...
And now when people are saying, I'm uncomfortable hearing this or talking about...
She's very uncomfortable, people.
Well, but no, not me. I'm saying, if someone at home is saying, I'm uncomfortable hearing this, I say... No, this is your body. This is your health.
I have a really good analogy that I've started to use with people. So you never show up to the doctor and say that you have face pain. Okay, we have like 10 doctors for the face because you would never go to the dentist with eye pain. You would never go to the dermatologist if you needed an ear, nose, and throat doctor. We go to like 10 different doctors for anything that goes wrong with our face. We've got plastic surgeons, we've got neurosurgeons, we've got all these people. Yet no one knows what's going on with their genitals. They don't even have the language. Everyone calls it a vagina when they mean the vulva. They don't know where their clitoris is. They don't know that they have labia, let alone that they shrivel up and disappear in menopause. And so when women do not have have language or access to their own body parts. And what happens when you go to the doctor? Okay, they have a sheet, and it's like they're mechanics looking under the hood, sort of like, let's get in and get out of here as quickly as possible because this is weird and gross. That's essentially what they're telling you. They don't teach you anything. They don't show you anything. And so where do you learn, right? You expect your partner to know your buttons and know what's going on because they don't get a lesson either. And so when do we give women access to their own body parts? And so, but they change, like these body parts are changing, which is why sex changes in menopause. Urinary health changes in menopause. You leak more, you itch more, you feel uncomfortable more, but women don't have the words. So they just say down there, or they just sit and suffer. And I hate when women suffer when they don't have to. It's one thing when we don't have the answers because medicine hasn't decided not to study women for 30 years. But when we have the answers, and vaginal hormones, vaginal estrogen is like the thing. We have answers. It's been safe. We've known for decades. It's not expensive. The fact that women aren't being offered it is, to me, a nightmare.
And to me, this is so much about learning about this and removing if there's shame or secrecy around it, is all about women and men living better, healthier, and happier lives. It's as simple as that.
It's so simple. If you give people information about how their bodies work, they get to decide
and by the way,
do.
Everybody's interested in it. They may be being, I'm uncomfortable hearing this conversation, but everybody actually is totally into it and being like, I need to know more.
Yeah.
Including, you've had big-time celebrities ask about, is this really true that the labia minora disappears?
Yeah, so when this went viral, so I did this little podcast, talked about the labia minora. It went so viral on TikTok, which I'm not even on, by the way. People were doing reaction videos of being in shock that their labia disappear and nobody told them. And it went so viral that I got a text from a celebrity who said, Kim Kardashian wants to know if this is true. And I said, well, and the celebrity said, well, if Dr. Rachel says it's true, then it must be true. So I think the truth is that women don't know this. Women are furious about this because they're like, why didn't anyone tell me, right? I'm smart, I'm educated, I can learn, I can take it. Why aren't doctors telling me? And the truth is, healthcare for women is really not optimal right now. If you're going to the doctor once a year with your legs up in stirrups for a pap smear, like that's not healthcare to me. Like it doesn't, you need to actually sit down and talk with someone and have conversations about your particular health, right? And what's going on with you.
Back to the conversation too, and rounding about hormone replacement therapy. We talked about systemic estrogen. We talked about progesterone. We talked about vaginal estrogen. What about testosterone?
Yeah. So testosterone is this thing that everyone is like, we're talking about a lot more, right?
Well, everyone says testosterone is a male hormone. Is it?
Yeah. So testosterone is a human hormone. The ovaries make testosterone. The testicles make testosterone.
Everyone goes, really?
And
there's testosterone in women?
Yeah. And so actually, fun fact, there's more testosterone. Women make more testosterone than they make estrogen. In fact, you even need testosterone to even form estrogen in the ovary. It goes through that pathway. And so we forgot to teach everybody this. We forgot to teach doctors this. And so there's global consensus, actually, that testosterone helps with low libido in menopause and perimenopause. And so the problem is we do not have a product in the United States that is FDA approved for women for testosterone, which is a huge problem.
But by the way, and you could probably speak to this, this is just based on my anecdotal evidence, but I would say that most very wealthy billionaire men who have access to the best healthcare are all on testosterone, as are their partners.
Yeah, that's true.
Why?
Well, when men's testosterone gets low, now men don't get to castrate levels unless they have metastatic prostate cancer. Men, they get a little bit low, say their testosterone's lower than 300 or 350 and they're feeling tired, they have erectile dysfunction, they're feeling low libido. If you give testosterone to those men, they feel much better. Most of them feel much better. They get in better mood. They get better bone density. They get better sexual health. Their libido goes up. They just feel more like themselves.
Their muscles get a little bigger working out.
Their muscles get a little bit bigger working out. And so they did a big study about testosterone, 5-year study. They gave it to old men with bad hearts, and it showed that it wasn't that serious. It actually helped them. It didn't really hurt them. It wasn't very dangerous. Now, the problem is testosterone for everybody is a controlled substance. So it is, you need a DEA license, and it is like you are prescribing opioids, actually. So we're really advocating to the FDA to change this because it makes no sense. It's based on the doping scandals of the 1990s and some bodybuilders that went a little too far with anabolic steroids. And so many of us are really advocating to the FDA to change this ruling because it's hard for women to access testosterone.
What would testosterone do for a woman?
Yeah, so we have global consensus that testosterone works for libido for women. But I will tell you, my patients tell me it helps with a lot more. It is the thing I see so many patients come back and say, oh, I just feel more like me. And the data shows it doesn't just help libido, but it helps arousal. It helps orgasm. I have patients who tell me it helps with their mild stress incontinence because the urethra, the tube you pee through, has testosterone receptors in it. The pelvic floor is full of testosterone. Your biceps have testosterone. So when you're lifting weights, you actually can maintain more muscle mass. Now, the problem is because we don't have a product in the United States, there is limited research in it. And by the way, it's been studied. 5 years of data went into it and it showed that it was effective and that it was safe. But because this was done around the time that the Women's Health Initiative came out and the warning labels on estrogen products were placed, the FDA was too afraid to approve these products. And so they actually did not approve them. So we've had 20 years of no products and no companies trying to launch a product, even though testosterone is approved for women in Australia, New Zealand, South Africa, and England. And so we're really...
In England?
Yeah, and England. And so we're trying really hard to get some of those companies to say, hey, maybe if you come to the U.S., maybe we could have a different conversation with the FDA now that the warning labels on hormone therapy products have been lifted. Mm-hmm.
And I've never talked about this publicly before, but I use testosterone.
Tell me more.
Prescribed by Dr. Rubin.
Tell me more.
But it is normally in a tube that is prescribed for men.
Yeah. And
that tube just... Explain how you say women should use that.
So women make about 1/10 the amount of testosterone as a man. So if you say men, the 300 to 1,000 is sort of normal male testosterone, then 10 times less is like 30 to 100. So we kind of that's kind of the range that we look for. But that being said...
A man may use an entire tube or half a tube on their chest.
So a generic little tube of testosterone, a man would use the whole tube every single day, but my female patients need to make that tube last about 10 days. And so it's not that serious. It feels serious, but it's not that serious. I say, Norah, take a blob, put it on your hand, rub it on your leg, wash your hands, and move on with your day. It's not that hard. Like
Right.
And I always tell patients it takes a while to kick in. For many of my patients, I always say it takes like 4 to 6 months for you to like notice that it works. And I literally had a neighbor the other day. She ran up to me. I was walking my kids to school, walking home. She ran up to me with her dog and she said, Dr. Rubin. I said, oh, good morning. She said, guess what? The testosterone kicked in. I said, oh, that's great. How long did it take? She goes, 5 months. I feel amazing. And guess what? I said, what? She said, I quit my job because I'm starting my own thing, right? She had this like strength about her. She felt great in her own body. She felt like she had the strength to launch her own, consulting business, which is so exciting. So
that's why I'm starting this podcast.
Yeah,
it was the testosterone. I'm just kidding.
So what did you learn? Like when did you notice that it helped? And what did you notice that it helped with?
There wasn't like an aha moment for me, but I definitely think you notice it over time.
Yeah.
But it's in concert, I think, with the other hormones.
For sure.
Yeah.
I often do it, listen, you can just take testosterone, and I think that is an option in perimenopause when you still have a lot of estrogen around. And I do think if you are over 60 and you're afraid of estrogen, though I don't know that you absolutely should be, it is an option to just do testosterone. We have lots of patients who just use it for their libido. I'll never forget this patient in her 70s who was seeing me for low libido. We gave her a testosterone prescription after, discussing all the risks and benefits. And, at 3 months, we did a call. She said, I don't really notice anything. I said, just give it 4 to 6 months, I swear. And so then we did a call at 6 months, and I'll never forget it. She looked at me and she goes, it's working. And what was so interesting about the story is it wasn't working for her to have more sex with her partner, right? There were lots of issues around that. But she had this desire to get her device out and have a good time and have an orgasm and like enjoy herself. Like she
How old is this person?
She was in her 70s and she felt her own sort of desire back. And that was so spectacularly meaningful for her. Now, that's what I love about my job, because my job is not to tell you what kind of sex to have or what kind of sex to want. But my job is to get you to try to feel as much like yourself as possible. And I think that's really important, because so many people are, women shouldn't want. Like, as you get older, it's okay to not want these things. But if you want them, then there are tools in our toolbox to help you.
Yeah. I'm glad you're bringing that up, because I do think, and I want to address this again, as someone who grew up Catholic, but I had a family who was doctors. So these conversations were not off limit. But certainly as a Catholic, there is this shroud, and I'm sure other people of other religions too, is like, you don't talk about sex.
Yeah.
But why is talking about sex and having a healthy sexual life so important to having just a full, happy life?
Yeah. So if you're Catholic, you believe in family, you believe in love, you believe in connection and not getting divorced and like enjoying each other, right? Like those are the things that everybody sort of loves and believes. Like this idea of the more we understand the human body and the biology, which is not anti-religion, the more you understand what you can do to optimize your own health and longevity and wellness. And when you feel good in your body, when you feel good with your own health, that makes your connections that much better, that much easier. Your love, and so this idea that you have to get old and that sex is no longer part of the equation and it's just not in the cards for you, I push back on that, because sex can look a lot of different ways. Connection and intimacy can look a lot of different ways. And when you don't talk about it, you ignore it. And I think it brings people farther and farther apart when the goal is to bring people together. And so I'm a urologist. I take care of men. I take care of women. I love helping both sides of the couple, because a lot of biology can happen that brings people farther apart. And by not talking about it, it doesn't help the situation. Actually, I joke, I talk about sex like it's high blood pressure and diabetes, because when you understand diabetes and you understand what you need to do, you can live a better life. You can be healthier. You can feel great. And so the more people understand their sexual health and the biology surrounding that, the better they can sort of live their lives.
Mm-hmm.
This show is sponsored by United Health Group. We know women live longer than men, but did you know they spend 25% more of their lives in poor health? How can that be? Well, it's that women's care is often treated as isolated moments instead of a lifelong experience. That's why United Health Group is working to reshape women's health with a more connected approach to care, supporting women through every stage of life, from adolescence to menopause and every moment in between. This year, United Health Group was the first to expand coverage for doula care nationwide, helping more women access personalized support before, during, and after birth. And through community partnerships and in-home care, United Health Group is helping women with the greatest needs detect and prevent diseases like cancer and heart disease earlier. Because women's health is more than any single diagnosis or moment in time. It's about care that follows women throughout their lives.
Let's talk about sex and SSRIs. Because you've been identified as someone who's part of the menopause, but you're a urologist and a sexual health medicine specialist. And a lot of young people have asked that question about, and a lot of people are on antidepressants.
Yeah.
How does that affect sexual health?
Yeah, I just want to be very clear. This is a very important area of research and very important conversations that are very polarizing in the world right now. And as a urologist who takes care of sexual health problems, every medicine that we put into our body can have potential side effects, right? The FDA is not there to approve drugs to say they have no side effects. Their job is to say, do the benefits seem to outweigh the risks? And the risks are different for different people. And we are not that good at understanding the human body, and everyone's body metabolizes different. Everyone's genetic code is slightly different. And we are only just beginning to understand the different things, the different ways people metabolize different medications. And so antidepressants are a very not one thing. There's many different types of them. They can be extremely helpful for some people, but there is a lot of side effects that can happen that can be quite harmful for your sexual health. And so antidepressants we do see have significant sexual side effects in some people, not all people. And those could be erectile dysfunction, they could be low libido, they could be muted or delayed orgasm, they could be absent orgasm. And we see even more than sexual side effects for some people. They'll describe what we call sort of genital numbness. And what women and men will describe is it's like you're touching my elbow. I can feel that you're touching my elbow, but there's nothing sexual about you touching my elbow. And they lose that arousal response, that joyful connection. And it's the word we use often is anhedonia, sort of a lack of pleasure. And it's hard to make that better. And so our toolbox of how to fix it is limited. We have some success with some people, but it's not a one size fits all.
And is this a big area of research you're seeing now on this?
I wish I could tell you that there was a lot of research going into this. You have to understand
big area of discussion, for sure.
It's a big area of discussion by the patients. There are some researchers. We actually just gathered a group of these researchers together in Detroit, and it was actually quite beautiful. It was a room full of researchers throughout the entire world. There were people from Australia, there were people from Italy, there were people from Portugal, and we all got in a room together to talk about SSRI-induced sexual dysfunction, finasteride-induced sexual dysfunction, and
that's finasteride. That's
for the hair loss.
Oh,
and
that's not minoxidil, is it?
It's not minoxidil. It's different than minoxidil. And Accutane-induced sexual dysfunction. And these researchers were looking at it from mouse models to genetic issues to spine issues to neuroscience issues, and it was so incredible to watch. No drug company sponsored it. In fact, the drug companies don't love that we're all meeting, right?
Why?
Well, because the drug companies that studied all these drugs, they want to make their drugs look as good as possible. So sometimes some of the side effects get a little bit pushed under the rug and they don't get marketed as loudly and they don't want their drugs to be dangerous. They want their drugs to only be good, but all drugs can have side effects, every drug out there. The truth is many people need and rely on antidepressants to help them with very serious problems. And so, but we have to also validate the fact that there can be side effects and that we don't teach psychiatrists much about sexual health and we don't teach primary care doctors much about sexual health. And that becomes a problem when your patient is getting these drugs from telemedicine companies or from doctors that don't know anything about sexual health. So they're not giving true informed consent necessarily. And I think that's where a lot of the problem lies. So
it's worth asking your doctor about if you're taking an SSRI or if you're considering taking one, is have that discussion.
Yeah, and the problem is your doctor may not have all the answers, and that can be very scary too. We live at a time where we are learning things, but we don't have all the answers, and we want to have all the answers. We wish we had all the answers, but we don't.
What about GLP-1s, Ozempic, Wegovy, Zepbound, and sexual health?
This is a super interesting area of research, and we started doing studies on this because we anecdotally, right? I'm a sex doctor, so patients come to me with sexual problems. So once all these drugs started getting prescribed for diabetes and obesity, patients would come to me, and some would say, Dr. Rubin, I have never been more comfortable in my body. I feel great. I have no interest in sex whatsoever. Or the man would come to me and say, oh, I feel great. Everything's good. I can't orgasm. It takes me forever to have an orgasm, and I'm so frustrated by it. So it got us thinking. We sent out a survey to thousands of people on social media to say, hey, you take GLP-1s, what's happening? And we found about a 10 to 15% of people sort of said that they had some kind of sexual challenge with the GLP-1. But here's where it gets kind of interesting. We published not too long ago a case study of a woman who had a devastating medical problem. She had persistent genital arousal disorder where she felt like she was on the verge of orgasm 24 hours a day. It's a suicide-inducing medical problem that we have had lots of suicides in the community for. It is often, we don't know, it's different causes for different people, sometimes spine pathology, sometimes you took a medication that it was a side effect, but women and men sort of feel this uncomfortable feeling 24 hours a day. Devastating. This woman took a GLP-1. She took tirzepatide for her weight gain, and she couldn't leave the house because she was so uncomfortable and miserable. She gained a lot of weight. So her doctor gave her a GLP-1 that was indicated for her weight, and her persistent genital arousal went away. It went away. It was gone. A week later, her shot was due to do again. Her symptoms came back. She did the next shot. Her symptoms went away.
And that's a very rare case. But for most, how would you say, millions of people are now on GLP-1s for weight loss. Does that benefit your sexual health? Does it not?
I think what we're seeing in the literature is that for some people it can affect their sexual health. So low libido, delayed orgasm. We do see some people with anhedonia, that word again, of that lack of pleasure. So you're not hungry for food. You may also not be hungry for sex, just like they're saying you're not as hungry for shopping or gambling or drinking. And so where the brain centers of dopamine and joy live, and some of these sort of I need sugar, right? Like there may be some connection to you may not want sex as much. And so there is a potential for, boosting dopamine in other ways, right? We have FDA approved medications to help with libido. We have hormones that can boost testosterone that we know work for libido. And so for a lot of my patients, we're playing with this. If you do find that you have side effects, we are using other things to help boost dopamine and sexual health. So I don't think it's a one size fits all. I don't think everybody who takes a GLP-1 has sexual side effects. In fact, some people have never felt better. And so, but if you are experiencing, I think their main point is if you have any changes or frustrations with your sexual health, there should be a medical provider who can help you. Yeah. And there aren't enough of us.
I mean, it's an interesting discussion because in 2026, there are so many drugs that can help us, whether they're the weight loss drugs, SSRIs, hormone replacement. I mean, we could go on, but there are, as you pointed out, there are side effects for all of these drugs, and they're part of the conversation you should have with your doctor.
Yeah, the challenge is finding, one thing I think is we forgot to teach doctors about hormone therapy, and we don't teach doctors anything really about sexual medicine. And so your doctor's never going to bring it up. Most of your doctors are never going to bring it up. And so when you bring it up with them, if they dismiss you, if they minimize, if they say it's all in your head, you have to know that
Is that called gaslighting? Is that what that means?
It is, but I think it's not, I don't think your doctor isn't intentionally being a jerk. I think that it is very hard. We doctors don't know everything. I've made a career off of being like, oh, we don't have any data. We don't know this. Yeah. But doctors have a hard time, especially when patients come in and say, hey, I saw Dr. Rubin on Instagram say there's a drug for low libido. They have two options there. They can say, oh, that's so interesting. Let me watch the video with you. Oh, let me go learn something. Or they could say, oh, Dr. Google, only I know everything. You don't know everything. And I wish doctors didn't choose that option so much, but they do sometimes.
Now it's myth-busting, true or false. Menopause symptoms are just something women need to deal with.
False.
The only symptom of menopause is hot flashes.
False.
Estrogen patches cause weight gain.
No definitive evidence, but if it happens for you, then it's real.
Hormone therapy for menopause is affordable.
Yes.
Sex after 50 is supposed to hurt.
No, false.
If you're 60, it's too late to start hormone therapy.
False.
You can only be on HRT for 5 years.
Definitely false.
How long can you be on it?
Till death do you part.
Doctors spend less than a day learning about menopause in medical school.
True.
Is that the biggest travesty of all time?
Yes.
One of the biggest, yeah. One of the biggest.
One of many.
Let's talk about hormone replacement therapy and Alzheimer's, dementia. Could it help prevent those in women, for instance, if you're on hormone replacement therapy?
Listen, I just got back from a phenomenal conference at the Cleveland Clinic with Maria Shriver and the Alzheimer's Foundation that were really just focused on what can we do to solve this problem. It is a huge problem, and women are so much more likely to get Alzheimer's than men. Women don't even realize that they're so much more likely to get Alzheimer's than men, and the research is more robust than it ever has been before. There are people, really smart people, and a lot more money that is going into figuring out this problem. The challenge with Alzheimer's.
The problem, why do more women get Alzheimer's
right?
and dementia?
And how can we prevent it, right? What is the way to prevent it? How can we treat it if you get it? So there are a lot of smart eyeballs looking at this. And the thought process being, well, women make more estrogen than men. Is it a hormonal cause, right? Women become castrate, men don't. And so is it that loss of estrogen that increases your risk for Alzheimer's? And the problem with this research is it takes so many years to do a trial and actually see the changes and see the differences, and the way that we study it has evolved as well. And so again, I'm a urologist. I can't begin to tell you that I am an expert in brain health, but I do think I think one of the things that has been really burned into my own brain is that Alzheimer's is not a disease of an old woman. It's actually a disease of people in their 40s and 50s.
Meaning it develops at that age.
Then, but you're symptomatic.
So interesting.
It's like GSM. It's like the genitourinary symptoms.
I know you're being careful talking as a doctor, but do you personally believe there's a relationship between menopause, the castration of all those hormones, and the increased risk of Alzheimer's and dementia for women?
So as a urologist who's so curious about hormones and is kind of obsessed with this concept, how could it not, right? Like your brain is full of estrogen receptors. Lisa Mosconi has proven that at 65, the estrogen receptor density increases. It increases because your brain is so hungry for estrogen, it creates more receptors to take every morsel it can find. Weight, right? Your fat cells make estrogen, which is I think why people gain weight in menopause, because they need to feed the brain. The brain needs estrogen to like fuel it. And men are walking around with estrogens of 25 and testosterones of 500, and their brains are getting coated in all of these hormones. And so how could it not? So I think of it like if in perimenopause, I actually think this is happening in perimenopause, because what's happening is your hormones go high, then they go low, then they go high, then they go low. And I think your brain is glitching. Like I think the inflammation that happens in that moment of like, it's high, it's low, it's high, it's low. I think your receptors are like, what the is going on, right? And so how could it
That's
not?
your personal theory.
That's my personal sort of thought process there. And so again, I am guideline driven. I don't have patients coming to me saying, Dr. Rubin, I want hormones for dementia prevention. They're coming to me because they have hot flashes, night sweats, they're not sleeping, they don't feel like themselves. Do I think earlier hormone therapy is beneficial for their brain? My money's on yes.
And to put a finer point on that too, because you brought it up, which was this EKG like in hormones that happens in perimenopause, which is so important because so many women say, like, what the heck happened to me 45, 50? And a lot of women go on antidepressants then. A lot of women end up getting divorced. Lots of issues happening because of this EKG. They call it something chaos, right? What do they call it?
It's hormonal chaos.
It's hormonal chaos. And explain biologically, essentially, what's happening. It's also a lot of women in their 40s also end up having twins, too, because your body's going, burp, 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 and it's just spurting out eggs too.
Yeah, don't have those whoopsie babies if you don't want them. So hormonal chaos. Perimenopause is hormonal chaos, right? So here's sort of what happens. To your point of the EKG, right? In a normally reproducing person, your estrogen shouldn't go to 0. Maybe your floor is 50. Maybe your ceiling is 150. When you're pregnant, by the way, 3,000, higher, many thousands, right? You have a very high hormone level, but when you're in menopause, it goes to 0. And perimenopause can be 0, then it can go to 1,000, then it goes 0, and it goes chaotically because your ovaries are sort of having a temper tantrum because they're almost done. And they're sort of fighting their last fight, and they are causing chaos while they're doing it. They don't leave the building quietly. And so for some people, that is incredibly symptomatic. One of my favorite diagnosis code, a paper was written called NFLM, Not Feeling Like Myself. I just don't feel like me. Something has changed. My sleep has changed. My irritability has changed. I had a patient just the other day. She said, Dr. Rubin, she was in her mid-40s. She said, Dr. Rubin, for half the month, I want to divorce my husband and I want to punch him in the face. I hate him so much. And the other half of the month, I love him to death and it's been great. And like, this is what perimenopause is doing to me, right? Like there is hormone, but no, don't blame it all on hormones. If your husband's a jerk, he's a jerk. But the truth is there are hormonal changes that are happening. And I'm so fascinated by that of like, where is, like, you don't feel like yourself. Now, there is some steadiness.
But this is like such an aha moment. And that's why I think talking about this is so incredibly important. Because I think that there are so many, and talking to my girlfriends, there are so many people that have said out loud, I think I'm going crazy. Mm-hmm. I think I'm actually going crazy. Or someone in my family is driving me crazy. Or work is driving me crazy. But in fact, there is a significant biological event happening in their body that is about to end in a castration, as Dr. Rubin would say.
A castration event. And like I'll get hate for this because people are still pushing the narrative of like, stop scaring women. This is natural aging. Like menopause is normal.
People are saying that you're scaring women.
people don't like when we talk about perimenopause. Like, there is still this idea that, like,
what are you scaring about? What's the scare?
They don't like that because this is natural. This is natural form of aging. Not every woman needs hormones, and I'm not suggesting every woman needs hormones.
Okay, well, that's a good question. Why isn't it natural? It is natural.
It is natural, but so is losing your eyesight. So are hemorrhoids. So are
So we can fix those things now.
We have technology. We have biology to help you not suffer.
So are cavities too. Like, you can fix that stuff.
So many women are suffering, and we aren't even giving them the information. You have to understand, my mission right now is to teach doctors how to write prescriptions, to teach nurse practitioners, to teach people how to write prescriptions, because they never learned. So we can be all fired up, we can be all excited, and we want everyone to go to their doctor and talk about this. They're going to be turned away because their doctor doesn't know how to do it. Doctor doesn't just magically know how to write prescriptions. Someone has to teach them. Someone has to mentor them. They have to see cases. They have to take courses. They have to learn about it. But it's not in medical school. It's not in residency. Like, so this year at the American College of Obstetrics and Gynecology, ACOG, the OBGYN conference, for the first year that there were menopause courses, and there was standing room only. There was like people were in like extra space watching it on TV because women are coming in every day asking for help, but unfortunately, there hasn't been anyone answering that call.
I'm going like this because I'm trying to like hold the steam in my head. That's like coming out of my head because I'm just like I'm like this is the root of all evil. Like the lack of attention on women's sexual health, and then the lack of. I mean, we're in 2026, and I feel like we're literally on just the beginning of learning about this. But you're teaching everybody about this that doesn't know about it, kind of prescribing every woman, who, by the way, every woman is a different size and is a different biological makeup, about the same thing. And we're going to be, you're the doctor, but my view is we're going to be 10 years from now, we're going to have multiple different kinds of doses, treatments for women, finally, because we're just at the teeny tiny beginning of this. Am I wrong saying that?
I think it's hopeful, and I agree with you. I think what I tell my patients every day.
Why isn't there like so much money flowing into this whole field? Because it's half the population, and we're literally like right here, the beginning of just, to me, which is, I mean, there are estrogen patch shortages.
Which is a huge problem, and is not just because more women want estrogen. It's because there is a monopoly on these, these like pharmacy benefit managers, and these are generic drugs, so they don't make them any money, and so they don't produce enough of them. And so it's this like crazy thing that like
they're pretty expensive for generic drugs.
It's not profitable enough. Like, they're just not making enough of them. There's like 3 of them. There's like 3 companies. It makes no sense. Like, we need more industry. We need more companies in this. But not everybody agrees with us in this idea of like people are okay with the status quo and are not really.
What's preventing this revolution in women's health?
I think it's a lack of education on the medicine side. So I think your primary care doctor doesn't know enough about this. Your gynecologist doesn't know enough about this. So whose responsibility is it to write hormone prescriptions? I would argue it's everyone who takes care of women.
And why isn't Big Pharma also found this to be a profitable
Because they're generic
enterprise?
Because they're generic drugs now. So there's no money in it for them, or they don't see the money in it for them. And so they're finding other new ways, non-hormonal things to help women. Why not just use hormones? It doesn't make any sense. So I think it's going to change it. So let me just say that now that the FDA removed the warning labels on hormone therapy, so for everyone listening, in 2025, for 20 years, all hormone products, regardless of type, dose, and ways to do it, every hormone therapy product had a big box warning label that said causes stroke, blood clots, heart attacks, probable dementia. None of that was true, and all of that was based on a study from the early 2000s that studied a pill version, 1 pill, 1 dose of a synthetic fake estrogen progestin combination. It had nothing to do with progesterone or natural estrogen or testosterone, like it didn't, or vaginal hormones. It didn't have to do, but all products sort of got this warning label. Well, in 2025, the FDA announced that they were removing that warning label, which is so excellent, and I think is going to spark a lot more interest in this. I've seen more interest. We've seen more interest in the OBGYN conferences. I've been lecturing to primary care clinicians. I lectured 3,500 a couple weeks ago. I lectured 2,000 just yesterday. And it is electric. They're learning about this, of sort of like, what are you afraid of? Doctors don't want to hurt you. And no one taught them that hormones were actually quite safe. And so they don't know the toolbox. They don't know how to do this.
So if you're sitting and if you are listening to this and thinking, I've got to do something about this, who should you go to? Your general practitioner, your OBGYN, who can help?
Yeah, so I would find someone who actually has an interest in hormone therapy and menopause. The Menopause Society, menopause.org, is a great website to find someone who took a test and has interest in menopause. That doesn't mean they know everything, but that's a great place to start. You could also go to a website called isswsh.org or ISWISH, the Women's Sexual Health Society. They have Find a Provider as well. And so those are people who know hormones and sexual health a little bit. Those are two great places. There are telemedicine companies that have really gotten into this space. So if there is no one in your area, that is also an option, some of which take your insurance, and you can meet with somebody online.
You know, the effects of not treating perimenopause and menopause can really affect a woman's life. And we know from the data that this change in life, perimenopause and menopause, happens at just about the same time that a woman is, starting to begin to reach the peak of her career. And then so many women say they want to drop out of and do drop out of the workplace.
Yeah, we see it all the time. Women are leaving because they don't want to be bad at their job. They can't remember words. They can't get things done. They say, wow, I used to be able to handle this level of stress and I just can't handle it anymore. And that is because of the hormone fluctuation and then the hormone crash that happens. And so women are leaving. And I think it's a tragedy. If you want to leave, of course, leave at your own free will, but you're leaving because there's a biological reason. That to me breaks my heart, because we have tools and options to help you. And I do think women are at the height of their careers. They have the most institutional knowledge. They have the most, that's my God complex. I believe when I can keep strong women in high places, I think we change the whole world. And so for me, I want to be that sort of person behind the scenes that's why I'm so nosy with everybody. Like I'm always like, okay, what dose is she on? But is that high enough? Are we doing this? Is she on this? Is she this is why I want Dolly Parton around for as long as humanly possible. And I know that I have a tool that can get her there.
You think treating perimenopause and menopause is the way to change the world?
I actually do. I also think it's the way we keep people married and happy together.
I totally agree.
When do people get divorced? Between 40 and 60. That's when perimenopause and menopause is happening. People are getting divorced every single day. A lot of people are getting divorced.
And so for husbands who are saying, yeah, my wife doesn't want to have sex with me anymore, it's not because they're sick of them. It's they're going through a change.
It's literally, if we cut men's balls off between 40 and 60 and castrated men between 40 and 60, they would also have a lot of changes and issues that happen. And so the more we can educate men about what's actually happening, the better. And there are solutions. There are biological solutions to help these people. And so I do think, and everyone's talking about longevity and the brosphere and manosphere and all the bro science stuff. The bros need to give a crap about menopause, because men who are single, divorced, or widowed have terrible health outcomes. Men need to be connected. They need to be partnered. They want to be among community.
Men need women.
Well, women will live forever because they all are friends and they love each other and they'll just hang out all the time. Men get lonely. They get isolated. They get, I'm watching, my mom died 1.5 years ago. My dad, watching my dad just sit at home and be lonely, devastating. Now that he's dating again, it's the most beautiful thing in the world because he's connected. Men who are single, divorced, and widowed have terrible health outcomes. How do we keep people partnered if they are partnered? Is we need everyone's healthy. We need everyone feeling good. And so men should care about women's hormonal health. They should care about perimenopause and menopause. They should demand research and funding and a lot more science. We need a lot more science. And then everybody wins.
This part of the episode now is when Dr. Rachel Rubin turns the tables.
Turning the Tables is sponsored by United Health Group, working to close the women's health gap.
Do you want to talk more about your personal story at all? Because I do think people would be
What's my personal story?
Your hormone regimen. People want to know what you're taking.
Well, I've never talked about this before, but I take testosterone prescribed by you. And I use a pea-size amount. I put it on the back of my calf, as you told me to do. I do it every night or every morning when I remember. And I think it's made a huge difference. And, a lot of my friends, I've taken a picture of what I take because there's such a lack of information out there. I mean, thank goodness to you and Dr. Mary Claire Haver and Kelly Casperson and so many other great doctors out there are sharing what they know on Instagram. But, I take an estrogen patch.
What dose?
I don't know, 0.5, I think.
Sounds right.
Does that sound right? 0.5. 100 milligrams of progesterone at night, which is a game changer. That helps you sleep at night. And so many of my friends have said it helps you sleep at night. It's fantastic. I also take magnesium glycinate at night, which I think helps me sleep. That's helps with muscles. I work out a lot. That helps. That's not hormone replacement therapy. That's just a supplement. Vaginal estrogen.
How do you do it? Is it a tablet?
I take the tablet. It's like a tampon.
Twice a week.
Yeah.
So you put this tablet in there, and
then I'm going to say something that really might be, I did get prescribed the estrogen vaginal cream, but I put it on my face.
It's a popular thing to do. So here's the deal.
Not all the time, but I think it helps with the wrinkles.
I put it on my face too. So
a couple of people did say during White House Correspondents' Dinner, they said to me, "You're aging in reverse," and I didn't want to tell them that I'm putting vaginal cream on my face.
Yeah, so it's very popular right now. And the truth is, estradiol cream, right? The reason it helps, it's skincare for your, down there. It also can be skincare for your face. Now, again, you're on progesterone to protect your uterus, meaning if you use unopposed estrogen, if you use estrogen and not progesterone, you do over time can increase your risk of uterine cancer. But you're on progesterone to protect your uterus from developing an overgrowth of cells. And so for you to add a little pea-sized amount of estrogen on your face to help with moisture, to help with wrinkles, it sounds like it's been very beneficial for you.
Yeah, I don't use it all the time, but when you're feeling a little older or wrinklier, I start the regimen back up again.
I'm not mad about it, and we really do need more dermatologists, right?
My dermatologist said there's no science behind it.
There is science. There
Between
is data.
Using it on the face?
Yes, there's data. Just because she doesn't read the data doesn't mean that there's no data.
Okay,
there's data.
send me the data because I'm going to show it to her.
Happy to.
Yeah.
Yeah. So I think that's so brave of you to talk about this because people are nosy. People want to know. Listen, you're very casual in a t-shirt, but my goodness, you look so hot.
Well, thank you. But my shirt says, when women support women, great things happen.
And look how great you're doing.
Yeah. And I am trying to support other women by sharing what I think can change people's lives. I'm in that age zone. I've seen so many of my friends suffer with frozen shoulder, having severe mood changes, the inability to sleep at night, divorce, separation, unexplained weight gain, even though they're incredible athletes who work out all of the time. So I just see it. I see my friends in some ways suffering, and then their doctors tell them that they don't need anything.
Can you tell people what, because you are very good at lifestyle, right? You eat very well. I watch your exercise videos on Instagram. I'm addicted to them and very jealous. How do you have time? How do you have time for all of this? Because you have a podcast, you're on TV all the time, you've got kids, you like how do you do it? And you were doing it before hormone therapy and then you after hormone therapy. Can you tell people like what that changed in you now that you're sleeping and what else you learned about hormone therapy?
I only think just one of the benefits of being a journalist is being naturally curious, being surrounded by a naturally curious team. So I seek out the best people in everything. So getting advice from people, I think, has made my life healthier. So whether it's the best doctors out there who can prescribe me the best care, the best trainer who not only I think teaches mobility and strength and has since I've been working out with Kira Stokes for more than 10 years, has been talking about the importance of building muscle for it's probably almost 15 years I've been working out with her. But even with her, it's just, even if it's only 30 minutes at a time, or even if I get on the treadmill for 15 minutes, I just say it's better than nothing. Mm-hmm. So, it's a lot messier behind the scenes. But I do believe that food is medicine. Mm-hmm. And I do believe that food can heal the body, not in replacing like hormone replacement therapy or other types of drugs, but I do believe you can change a lot about your life by what you eat. And I kind of live by that motto.
So I think it's really important. Nobody is out here saying, just take hormones. It fixes everything. Right. Of course, the lifestyle changes are important. You had done great lifestyle before hormones, and you're continuing to have a great lifestyle, good lifestyle choices on hormones. What do you find was the most beneficial thing? Was it that you had better sleep? Was it that your brain felt better? Was it that your mood was better? Like, what did you notice the most about like, hey, I like this and I want to keep refilling these prescriptions?
Well, I think the first time I noticed it, and I was, anchoring in New York in the morning show, and I had 3 young kids and was traveling back and forth between Washington and New York on weekends. And I was in the airport and I called my doctor then at the time and just said, I feel like it's in the movie like Inside Out. And I feel like someone is just flipping a switch. So for me, it was emotional, meaning I felt this emotional wave coming over me, like that something was turning off a switch for me. But I think in using estrogen, progesterone, testosterone, vaginal estrogen, in addition to all the other stuff I did, one helps me sleep better, certainly helps my mood. I think it's helped my skin in a lot of ways. I think people don't realize how much collagen loss you have. So I think it's all of those things. I don't have, musculoskeletal issues. I mean, definitely at 52, even on all those things, you start to have musculoskeletal issues that are just part of aging. But I think it has improved with those things. Does that sound,
I think it's amazing, and I think sharing it is really, I think that's part of why we've
sharing
been
is caring.
So successful,
That's what we
right?
said growing up.
To many people, like, they don't know that you're really a human, right? You're just like, you're so like, I don't know, you look perfect, you sound perfect, you're so smart. It doesn't seem fair to us regular people out there. And to know that there is biology and there is, the exercise and the eating right, and that you invest in you. I think for a lot of people, I think it's going to be really important for them to hear that people who look like you don't always feel perfect, and that there are things that you can do to help to like improve the quality of your life.
I do believe that women caring for themselves, their mental and their physical health, is about changing the whole dynamic and allowing women and helping women rule the world.
I couldn't agree more.
Like, women are amazing.
They're amazing.
Women are amazing. Women do
amazing.
so much. Women care for their families. They bring home the bacon.
Yeah.
They fry it up in a pan. And they just need the health care that they deserve.
Yeah, and they need a team around them to support them, and it's okay to ask for help. And I think one thing as a doctor, like, it can be very intimidating to take care of a celebrity, right? Because I've seen you on TV for a very long time, and there is that ability to just have that human connection and to say, hey, I'd like to help take care of you, and to sort of see you as a human being who has medical issues. And I'd like to, again, to be able to explain things in a way that makes sense to you, and to convince you that like there is like sort of medical things that can be helpful. And you were very receptive to that. And I think that it speaks loudly. And I think all women need to hear that. Like, just because you're the height of your field or you're the best at what you do, finding other people who are knowledgeable about things that you might not know about. And don't put your head in the sand. Don't think that yoga and deep breathing and meditation is going to fix everything. Like, there is a lot of biology and science that we do know about women. Even though we have a lot more to learn, there's a lot that we do know, and that you don't always have to feel badly or suffer. There's a lot of times an option to help you.
What do you think about some of these companies that are now providing perimenopause supplements?
Yeah, so my take on supplements, you'll actually never hear me talk about supplements fully. And it's really because supplements aren't fully regulated by the FDA. And so we don't even know if you have a bottle and it says that this is what's in it, there's actually no one looking in that bottle and making sure that's what's actually in it. And so...
You mean I can buy something by a reputable company and we don't know what's in it?
There have been studies that have looked at that, and it's not always what it says it is in the full amount. And so we have enough challenges with the FDA having medications that are fully safe, although it's they have a lot more oversight and testing. And so it's just not my space. It's not my expertise. There are no supplements that are absolutely magical in my line of work that actually are better than the hormones and the medications that I have to offer. So I'm not a big supplement person. That being said, vitamin D can help a lot of people. Fiber can help a lot of people. We know, we know that cranberry supplements can help prevent urinary tract infections, but nowhere near the amount as vaginal hormones can prevent urinary tract infections. So when people ask me what supplements can help my erectile function, how about eating right, sleeping well, and using Viagra? Like, those are really good things to help.
You're pro Viagra.
I'm very pro Viagra. Who wouldn't be pro Viagra? Who is not pro Viagra? I think Viagra should be in the water, right? Everybody should have some. It helps female arousal as well, by the way. It's just most women have low libido and hormonal issues and hormonal problems in their genitals, so they don't respond to the Viagra as much. But if you fix all those things and give a woman Viagra, it works great to increase blood flow to her clitoris, just like it increases blood flow to the penis. So it can work very well. And we know that Viagra can help men's cardiovascular issues. And so why aren't we studying that in women? Like we've published on this. Why aren't we studying PDE5 inhibitors for women's cardiovascular health? Please, because they're generic drugs and they don't make anybody any money. And so nobody wants to study it. And we don't have NIH funding anymore for anything. So it's a challenge.
Thank you, Rachel.
Thank you.